My name is Thiago Fukuda. I'm from Brazil. I'm a PT, I'm a physical therapist from Santa Casa in São Paulo City. I did my PhD in Brazil and my postdoc in States at the USC, University of Southern California. And I'm here talking with a legend, with Dr. Donald Neumann. He's a professor from the Marquette University in States. And he came to Brazil for a conference for the International IBRMAT meeting. And we are very proud for receiving Dr. Donald here in Brazil. And Donald, thank you for coming.
Pleasure to be here. Pleasure to be here.
That's nice. That's nice. So, congratulations for your job. Congratulations for your studies, your work. Congratulations for your book. We use a lot your book in Brazil in all universities. Your concepts about biomechanics. And so, are you enjoying Brazil?
It's been great.
Having fun?
Well, it's a lot of work, but it's you're taking care of us. So we have good times at night, but we work hard during the day. So I'm loving it. Yeah,
that's good. That's good. You're ahead for that. So it's our first time in Brazil?
Well, I actually visited Manaus about 10 years ago and went on a river trip to the Amazon River.
Ah, okay.
So, but the first time in
how was that?
It was great. It was
it's warm.
Warm and a lot of animals. I mean, it was very interesting. Yeah.
Next time we should come to the beaches and having fun. So on your presentation, and I can see in your studies the biomechanical view, a different biomechanical view of the hip muscles. And you always you always tell us about the 3D view of the hip muscles, the 3D function of the hip muscles. I realized that it's really important when you treat a patient in the clinical practice. I'm using your concept because I really believe that if we perform strengthening of the abductors, hip abductors, lateral rotators, and extensors at the same time. We can control the dynamic valgus, the medial collapse of the inferior limb, the medial collapse of the knee. And in my opinion, it's very important for treating patients with patellofemoral pain, with femoroacetabular impingement, ankle sprain, ACL injuries.
Sure.
So tell me about, do you really believe in this 3D function?
Well, the way I try to understand kinesiology in general is I go to the individual joint in question, this case being the hip joint, and first analyze how many degrees of freedom does it move in. And the hip, of course, has 3 degrees of freedom. So I visualize this three-dimensional axis of rotation, vertical, anterior, posterior, medial, lateral. I place it on the femoral head, and then I visualize where the lines of force of the various muscles cross there. And then by that, you know what the action of the muscle is, or its relative leverage. And when you change hip position, the muscle lines of force may cross to the other side of the joint. So a muscle, like for the piriformis, for example, if you're on hip extension, that muscle produces external rotation. In extreme hip flexion, the same muscle may produce hip internal rotation. And that's because of the muscle line of force is moved when the femur moves, so it changes its action. If you didn't think about that conceptually in 3 dimensions, you would never be able to understand that. So I think understanding the 3-dimensional anatomy and muscular biomechanics of the hip is essential. And as you mentioned, the hip controls not only everything above it because of the trunk is related to the pelvis, but controls everything below it. So I firmly think the hip is kind of like the central pivot point of the entire body that really needs to be controlled.
Perfect. And I really agree because I'm treating patients with knee pain with this concept. I really believe that the true core the muscles around the hip, because if you have an unstable pelvis, if you have a huge pelvic drop to the contralateral side, all the trunk is gonna lean laterally, and the lumbar muscles, the low back muscles will compensate with a hyperactivation. So I really believe that this kind of strengthening is important for controlling the whole body. And I started using a different term. I always talk with my residents that the key is the posterolateral hip musculature. So this 3D view when I perform an exercise, and so that's nice for me, knowing that, realizing that you have the same sure. feeling and the same idea. Sure. That's nice, really nice. What do you think about the posterolateral hip musculature, about this term?
Well, I think it's good. I mean, a lot's going on in those regions. I mean, anything posterior lateral is a strong hip extensor and abductor, and many muscles actually share both those actions. Gluteus medius, its strong posterior fibers or extensors, lateral fibers or abductors. Even part of the gluteus maximus probably has some abduction component as well as extension. So I think there's a great deal of stability needed on that posterior lateral corner. Not only for stability in single limb support, but for propulsion forward.
The cross-sectional area is huge as well. And so, a different question now, a different idea. What's your opinion about the biomechanics and the clinical practice? Do you really believe that all PTs should incorporate the biomechanics on their clinical practice? Do you think that biomechanics is everything?
Well,
it's really important for knowing the movement, the motion.
Well, there's a lot of elements to understanding human movement, and anatomy is essential. Probably backing up principles of physics are important. Understand torque, kinematics, kinetics, and then knowing your human anatomy is essential, including muscle, joints, and then biomechanics to me, or kinesiology, is putting those two together, layering the anatomy on top of the biomechanical principles. Because we are really a machine. I mean, and if you go to your car dealer, you would expect them to know how the car works before you can fix it or to diagnose what's wrong with it. So I think physical therapists have excellent training in both anatomy and biomechanics. And the expression of that knowledge is in evaluation and treatment of patients. If you don't know through biomechanics, then you have no systematic way of determining what to do.
And I see a lot of people doing a lot of courses, techniques, different techniques, and new techniques without scientific basis. And sometimes you talk and the guys don't know about the base, the biomechanics. So
often those techniques don't last very long. I've been in physical therapy 35 years.
How many techniques
35.
have you seen?
So I've seen a lot of things change, but the concepts that tend to stay there are the ones that have a biomechanical principle.
And when did you start studying biomechanics? Since you were a graduate?
Well, I became a physical therapist in the mid-1970s, and I worked with spinal cord injury rehabilitation for about 5 years. And that taught me a lot about treating people to move with partial muscle innervation. Then I went and got my master's degree and PhD in biomechanics from the University of Iowa. And they have a very strong program.
Okay.
And then after that, I've been teaching at Marquette for 28 years or so, both anatomy and biomechanics.
That's nice. So, good.
So I've been studying it ever since the beginning, I guess.
Yeah. And changing a little bit the topic, I just submitted a paper to JUSPT trying to correlate the serratus anterior, the rhomboid, the inferior, the lower traps, strengthening in people with scapular dyskinesia, and we got good results. It's a case series of people. We evaluated the strength, the motion, the range of motion, pain, functional, functional activities before and after this scapula strengthening. So what do you think about this relation between scapular dyskinesia and shoulder impingement? Do you really believe that we should focus on the scapula and then on the rotator cuff muscles and deltoid?
Well, I think, as you know, the subacromial impingement is based on the distance between the humerus and the scapula. Either one of those bones can move independent of each other, so you can have that acromial humeral distance affected by either one. So probably both glenohumeral and scapular humeral muscles would certainly be involved, as well as thoracal scapular muscles. So I do know that it's a new area, which is interesting because there's been so much kinematics studied in the shoulder, primarily because of problems with impingement syndrome. We know now motions and kinematics of the scapulothoracic joint that we've never known before. So, for example, the serratus anterior, does it posterior tilt? Does it externally rotate? I mean, it looks like it does by a simple analysis, but it's actually, if you look in basic anatomy books, they won't have these actions there yet.
I really, that's pretty interesting because I'm still trying to do both, the clinical practice, the teaching and research. I know that's a hard work, but I love studying biomechanics, but in conference like this one, like that, in meetings, international meetings, I always absorb this information regarding to biomechanics, soft tissue release, strengthening, electrotherapy. So I use these informations on my clinical practice. So for sure, next week, when I go back to my office, when I go back to my clinic, I'm gonna apply a lot of new ideas that I learned in this weekend. So
great.
I think that's the point, to fusion between the base and the clinical practice. So thank you so much for coming.
Well, it's a pleasure.
So I've enjoyed with the conference, I've enjoyed with the Amparo, the city, São Paulo, Brazil. So you are very welcome to go back.
Well, thank you very much. Pleasure to meet you.